Thanks, Glenn. Oh, welcome everyone to this afternoon session. Would it be all right if our speakers introduce themselves rather than, I'll do a brief introduction of you, but I always find it's more comfortable for speakers to actually introduce themselves than me. We've got three speakers this afternoon. We start off with Professor Rebecca McGowan, who founded the pub-based men's health program Prick and a Pint, facilitating many programs with rural and urban men's health groups from 2016 to 2022. She's now the medical director of Wavelength Men and Wavelength Women, two innovative holistic health programs focused on practical ways to improve well-being for both men and women in corporate settings. I remember you so well from the last Men's Health Connected. It was great. Okay, Rebecca, let's move over to you.
Thanks, Greg. Hello, everyone, and thanks everyone for joining us here today. You've elevated me. I'm a doctor, not a professor, but a general practitioner of 30 years experience. And like many of us, I have a father, I have three brothers, I have a son that I'm married to, a wonderful man. So my passion in men's health has always been there, but in particular over the last 5 years in the rural area, I came to the realization that we were missing so many men in our community who actually weren't coming in to see their local GP. And there was a huge cohort of people with quite significant health needs who, as I said, weren't accessing us. So as part of a community group with 4 other men, we designed the Prick and the Pint, where we went out to pubs and we ran groups of 15 to 20 men, and we focused solely on prevention. And we ran about 13 groups across New South Wales and Victoria up until the beginning of last year. And we're about to start 5 groups in Melbourne, focused on pubs. And I'd done an amazing job recruiting passionate GPs, and we had 10 programs, 10 nights organised across the whole of 2020. And we all know what happened this time last year. So that could put the kibosh on that. But it helped us change direction. And what we realised is that as well as having a community focus, which we still continue to do, to go to men's sheds and go to football clubs and things like that, we decided that we also needed to have a corporate focus, because for 5 years it had been purely volunteered. And we thought for the long term, one is to get some remuneration, and the other thing is to also reach people who may not even come to a pub community group. And these were a lot of people who are factory workers or in the building industry. So we did a great segue across to making it more factory and corporate focused. And I've run a couple of groups with our local corporate here I live in the Albury-Wodonga area, and it's where Mars Pet Food is focused. So Mars have been very keen to have us run the programs there for them. So that's what we're doing. And it's really, COVID, like so many other people, it's really helped us refocus our business and to have more of a business model. So what we're doing now with Wavelength program, the actual process is that we're going to go into the factories and into corporates, and we have a different style. Rather than just delivering, say, 8 or 10 programs over a year, we have several different programs. One is that we can just go in and do a 2-hour program to deliver health prevention, which I'll go into in a moment. The other one is a whole day program, which is a Saturday program, which is very much hands-on approach. And then the third one is that we could just do 3 programs. So it's basically that we have diversified our program. And our program is called Wavelength because we actually focus on the build-up of a wave for conditions. very proudly say that we don't go into management and we don't go into treatment. We go into prevention. And the idea is that the wave is a build-up, for example, a build-up to a condition such as diabetes, and that if we focus on when the wave is building up, then we can help lessen the impact of when that wave crashes. And we have a very strong focus on what we call our 5 pillars. And our 5 pillars are finesse, FNESS. And F stands for family history. So we teach the men about the importance of family history. And we really encourage them to go and be detectives and go and ask their auntie or their grandparents or their parents about family history. We all know, for example, the impact that family history can have on heart disease, or the impact that family history can have on diabetes. And it's a resource there that men need to know about and take to their doctor. But so many men don't know their family history. So we focus on the F for family history. The N is nutrition. So we teach men about nutrition, and we teach it in a very practical way. For example, I would hold my hands out like this, and we would show them, a quarter palm size is protein, a quarter, like your fingers, is carbohydrates, and half of your hand is fruit and vegetables. And then we get the men all to have a look at what their hands hold, and we teach them about portion size. So that's nutrition, and we teach them about the importance of water and, drinking water. And one of the things we do is we teach men to bring these habits into habits that they already have. So, for example, water would be, it's not enough just to say you should be drinking 1 litre a day or 2 litres a day. We say every time you sit at the table and have breakfast, try between now and the next month we see you, try put in a jug of water at the table or a glass of water at the table. So that concept of, if you are going to bring in a new habit, tie it in with a habit that you already have. So we try and get all the men that we work with having water at least 3 times a day, and then in between. So that's the nutrition. Exercise, we're very big on exercise, and we get the men trying to do their huff and puff once a week. So the 150 minutes of huff and puff, and we explain what huff and puff looks like: fast pulse rate, sweating, short of breath, and you can't talk. So we get them all working on that. The first S is for sleep. So we teach men sleep hygiene, and we teach them how to bring good sleep habits into their life. And the last S is stress. So we do a huge amount on mental health. And the part of our wavelength, we call it wavelength 3 to differentiate it between some of the other wavelength programs out there. The wavelength 3, we look at physical, we look at emotional, and we look at relationships. And the stress part, in terms of looking at the relationships, is this big focus on understanding where you're at in life, what your stress levels are. Part of my passion is actually being able to give men tools. And one of the tools, for example, we use with stress or with looking at where their emotion is the K10. So we print out the K10, and we help the men to use the K10 and help them score it and understand what it looks like. The K10 is a really useful tool. I'm not sure that everyone listening to this knows about the K10, but as I said, we get people to get it on Beyond Blue or the Black Dog, but the K10, and we get them comparing their score as to how they were at the beginning of the program and how they were at the end. All of our tools, the framework is this idea of traffic lights, so green, amber, and red. So the K10, we teach the men that under 20, so it's a score out of 50, so under 20 is green, from 20 to 30 is amber, and over 30 is red. And this is the tool that you can use. So it may be a bit of a cliche, but we know that many of the men we work with, their response to us has been, we actually really like something written so we can gauge how we're going. We don't want this idea, well, monitor your stress and reduce your stress. It's much more useful if we've got this tool and we can say, here, where in March your K10 was 35 out of 50. And now that you've gone and used these tools that we've given you, your K10's actually dropped down to 21 out of 50. And we also give men a mental health plan to follow. So this is what you can do when you're in the green, this is what you can do when you're in the amber, and this is what you do in the red. The traffic light system we also utilise a lot, for example, with our diabetes. So we get most of the men, before they come to one of our programs, we ask them to do just baseline tests, and such as fasting bloods, blood pressure, and waist measurement, weight and height. So they bring all these parameters in front of them, and when we're talking to them, we can say, okay, this is what green looks like for your sugar level. Green is under 5.5. Amber is between 5.6 and 7. Red is over 7. So again, it is that concept of being able to give people a tool and an actual reading so that people know where they are on the green, amber, red. And we find that works. It works for men because then they know where they're at and they can say, okay, well, I'm in the amber, but I want to get to the green. The other thing that we find this works really well is that it's all care and no responsibility. So I'm not there as a doctor saying your blood sugar level is 7.2, you have to go and have this particular medication, or this is what you've got to do. Our programs, again, put it fair square back into the man's responsibility. And part of that is actually teaching men how to have a good relationship with their GP. So the GP is at the forefront of men's journey, their health journey and their prevention. And as part of that, we also teach them what a good relationship looks like with a GP and how to find a good GP and what a good GP looks like. And it was interesting, I had a man that I bumped into this week. It was actually in the mechanic shop. I had my car in there and he came up to me and he said, I went to one of your talks 2 years ago. And I'm always really interested what it is that men take out of the talks. And so I picked his brains and I said, well, what is it that you remembered? And he said, I always remember when you said that you need to have a GP who respects you. And if you don't have a GP that you've got a good relationship with, then get a second opinion. And I said, oh, well, tell me about that. And he said, well, the GP had just put me on cholesterol tablets and I didn't think I need to be on them. And I had side effects. And I said, well, what did you do? And he said, well, I went back to the GP and I told him that I was having muscle aches and pains from the cholesterol tablets and I didn't want to be on them. And I said, well, how did that go? And he said, the GP just told me off and said I'd been reading too much into it and I've been looking at the internet too much. And I said, so what did you do? And he said, I took your advice and I went and got a second opinion and I changed GPs. And I just thought that was fantastic because this was a guy that I never had anything to do with apart from 2 years ago. But that's the vibe that we want. So part of it, I guess our metaphors are, and it can be seen as a bit of a tired old metaphor, but it works. So we teach men driving your car is the same as driving your body. And when you drive your car, you read the dash. You watch what the petrol gauge is doing. You watch where your tyres are. You watch what your windscreen's doing. And you understand and you monitor it and you keep an eye on everything. And we say, this is exactly the same as your body. And this is what we're going to do. We're going to teach you. So in our wavelength programs, we say we're going to teach you how to read the dash. We're going to teach you what a good blood pressure looks like. We're going to teach you green, amber, red for blood pressure. And we're going to teach you what to do when you're getting into the red. We're going to teach you to pop the bonnet. We're going to help you look underneath your bonnet. And we're going to explain a little bit about what's going on under the bonnet. And we're going to help you drive, put your hands back on the wheel and be the driver. So I found that the men that we've done these programs with, and there's a couple of hundred now easily, really love that empowerment. And they say, you know what, I never even used to know what blood pressure was. The doctor never asked me. And now I've got it on my app and I take it in and I can use words like systolic or diastolic and I know exactly where it needs to be and I'm feeling totally in control of it. So that's what we really love. We love that empowerment. And as I said, I love the 5 pillars, the family history, the nutrition, the exercise, the stress, the sleep, and all of that comes in rather than just focusing on something such as prostate cancer, which is so often the paradigm here in our rural area. We have an ex-football player or a rugby player who comes and talks about prostate cancer. And no offense to anyone who's passionate about prostate cancer, but from my perspective as a GP, it misses out on so much that we could be doing. So we do prostate cancer, but it's a small focus. The prevention of all the other things are our big focus. And the other thing is the mental health. We talk about mental health every session. So the mental health will come up when we're talking about cardiovascular disease. It will come up when we're talking about diabetes. It will come up when we're talking about how to interact with the health profession. It comes up the whole time. So we have these threads, and mental health, relationships, physical and emotional health, they're the common threads. And as I said, we focus on all the different parts of the body, but the man leaves our sessions having an understanding of what's actually happening in his body, what green looks like, what amber looks like, what red looks like. And the man has an understanding of the tools that he can use going forward. And we're very proud of the program. And we also know that with these prevention tools that we give the men, that we can proudly and categorically say that we can add at least 5 to 10 years of good living to men's lives when they follow these prevention tips.
Sorry about that. Would you like to take some questions now, Rebecca?
Yeah, take some questions.
Okay, now we had a question coming in from Albert.
Yeah.
Now, Albert, could you just ask your question? He's there. Albert's question that came in on the chat was, do you visit men's sheds?
Yes, I'm passionate about men's sheds. My local shed is Yakandanda in northeast Victoria. Anyone who's been to Yakandanda, it's a great men's shed, and yes, we do.
Oh, okay, great.
Local sheds. And if people have a GP that they would like to be part of our program, they can put their GP in contact with us, and we can educate the GP about our program, and that GP can go and visit their local men's shed. But we're very happy. It's not our knowledge. We want to share the knowledge.
Great. That's fantastic. Do people have any other questions just at the moment for Rebecca? You can raise your hand, or I'm trying to keep. Yep.
The other thing I was going to mention too, Greg, one of our programs, particularly a program where we'll go into a factory floor on a Saturday, we are aware that at least 10% of the population has literary issues, and probably higher in some of the so-called blue-collar areas. So our program is tailored for that. The day program is actually walking around, and we have stations. So we have a very visual component to it. For example, when we're explaining blood pressure, we have balloons with the hydrogen pump up.
Right.
And we will talk to people, this is why blood pressure is important. And this is why you need to actually look at your blood pressure and control it, because look at how much this balloon busts. And it's a real bang thing. So we will teach people, if you don't control your blood pressure, it will explode in your head or in your heart. And this is what bad looks like. So it's not necessarily just that passive, here's a handout sheet about systolic and diastolic blood pressure. Like, that's not going to work for a lot of our clients. So So the visual stuff we're really keen, or the rusty pipe. So we have a pipe that looks like that, and then we have a rusted pipe, and we show people what cholesterol does. So people come away with these visual things, and they say, oh, I always remember what you said about the rusted pipe and how I want to avoid that. And even though I didn't want to go on medications for blood pressure, I thought about that visual of that blood vessel exploding in my brain. So the visuals are really important.
I agree. I've run a Healthy Men in the Workplace program for about 15 years or more, and I agree with everything you're saying about keeping it simple and using good examples. I just had a bit of a thought when you were speaking about, you've used the word corporate. When you go into, say, a company, do you go in at the management level first and then the workers, or just straight to the workers?
Well, it's interesting. We've done both. So we've gone to the management level, and some of it's been quite disappointing because, again, I say, well, what would it take? What would it take for you to actually realise that you've got a group of men here who are hurting and need help? And they would say, well, it's interesting you say that because we've had 2 heart attacks and we've had 2 men suicide. And our Philip, when I go in with my co-worker, Martin is his name, and we go in and we say, well, you're already there. And some of the response is, well, we'll do a survey and see whether or not, and you think, don't do a survey. Look, you don't need a survey. You're already in the red zone. So the other thing is with the workers, we've had, because we give these out to the community, these talks, we've had the workers actually go and tap on the shoulder to them and say, we need this program in at our workplace, or this was fantastic, they've changed our lives, we want you to bring it back, and we've got other people on the factory floor, so we want you to do, we want the corporates to pay for it. So it works both ways. You come in top and you come in bottom.
That's great.
It's just very hard. We are finding it hard to break through. I don't know if it's COVID or just because corporates don't want to spend money, but for me, it's a bit like only treating people once they get a stroke or a heart attack. And again, my focus is on prevention, and I feel passionate about prevention. And it's just very hard to try and get corporates to see the value in prevention. I don't know if anyone else has got any tips on that. I'd really appreciate it.
Gee. Philip, you had a question? Philip Green?
You hear me now?
Yep, got
you. Look. I'm in the Positive Aging Committee with the local Shire, and we're looking at doing a program in conjunction with a couple of the men's groups, Men Shared and Omni and so forth, for 150 odd men in October, which sort of overlaps with Seniors Month in Victoria. And I'm just hearing everything that Rebecca's been talking about. It just sort of fits into this what we're trying to do is we want to present something to men, give a reason for men to come along, but not be told it is all mental health. And I think you've really touched on some great subject points there. So is there somebody that could come along and present the program at our forum? It's, as I said, we don't have any history on how it's happened in the past, but this is the first off, but we've got a lot of interest from people within council and men's groups.
Yeah, there is. Thanks, Philip, was it?
Yes. Yep.
Yeah, thanks, Philip. Yep, we are definitely, we're looking at councils. My local council in Northeast Victoria, we're about to run something for them. So councils we're really interested in, and with 150 people, we can do that. We haven't done that many. The most we've done is 50 to 80 people. And as I said, we do anywhere for small groups, but definitely by October, we would be interested in that. And if you go to my website, so that's Dr Rebecca McGowan, you can see our contacts and the people, the links through to my public speaking, and it will direct you. It's a contact us, so you can put in an application there.
Yeah,
but
fantastic.
We're passionate about going through councils. So yeah, very happy to help out. Where is your council? What part of Australia?
Yeah, northeastern suburbs of Melbourne.
Yeah, well, that's easy. It's only 3 hours away. Yeah.
Just one other quick question I'm just taking from the chat here. And the question's about how can doctors and naturopaths complement their work with men, presumably with men?
Well, I'll answer that. I think I work closely with some naturopaths as well. I always say there's enough sand in the sandpit, you know. We all need to work together, and some men won't necessarily listen to the doctor, and you know, let's be honest, a lot of doctors don't know a lot about nutrition.
No.
And some naturopaths know quite a lot about nutrition. So I think the thing is you're working together, and I reckon that GPs should know the name of a few good naturopaths to refer people to and read the room. If a man's coming in and saying, look, I'd like to learn a bit more, or I want to go natural, you say, great, I work closely with a great naturopath, I'll put you onto him or her, go and see them, here's a copy of your results, and come back and see me. But I also think that it's beholden on GPs to learn a lot more about nutrition.
Yeah.
So it's, as I said, there's no, it's one of our pillars, nutrition, nutrition, nutrition. We are what we eat. And if a doctor goes to a GP and the GP doesn't talk about nutrition, if a man goes to a GP and the GP doesn't talk about nutrition, the man, you know, can say, well, do you know someone who does know about nutrition? Or word of mouth. But nutrition is very important. So I think that doctors and naturopaths should work closely together, and there's good doctors and good naturopaths, and we need to encourage men to seek them out and use them.
Great. Thank you, Rebecca. And we will, hopefully we'll have some more time right at the end for some more questions. But I'd like to just move on and introduce Associate Professor Joanne Porter, who currently works at the School of Health at Federation University Australia Gippsland campus. Her roles include the Director of the Collaborative Evaluation Unit and Campus Leader in Nursing. Joanne, I'll hand over to you.
Hello and good morning. No, good afternoon. It feels like it's still morning. Sorry. I'll just share my screen. First, I'd like to say thank you for inviting me to come and speak today. And this is going to be a little bit of a snapshot of the things that we've been involved in Gippsland, so in La Trobe. And it's a snapshot of a multitude of different projects all around men's health. So can you see the screen okay, the PowerPoint? Yep, yeah. Great. All right. So I am the Director of the Collaborative Evaluation Unit, which is a relatively new unit sitting at the Gippsland campus of Federation University. We've been doing some work with the La Trobe Health Assembly and the La Trobe Advocate and the Department of Health around health in general, and evaluating projects and initiatives that are being run here in Gippsland region. So today's presentation, what I'd like to have a look at, a bit of a snapshot of different initiatives across the ages, really, across the ages. There's a number of things happening in the smoking cessation area and the initiatives around getting men in particular to either reduce or to stop smoking. The cancer screening space, and in particular bowel cancer screening, and in particular, of course, suicide prevention, and that's across and will continue to be. But in particular, there's a couple of key initiatives happening in this area due to, a magnitude of different calamities and disasters that have happened in this region that seems to be one on top of the other. I want to talk a little bit about some physical activity programs that have been begun in this area and their impact to men's health, and talk about some initiatives in actually taking it out to men to do health checks and to get them screened. So one of the big initiatives that's happening is, and something to keep in mind, is that the smoking rates in Victoria are about 13%, but in La Trobe Valley, they are as high as 24.4%. So we've got a much higher number of men that are smoking in this region, and our smoking rates, because they're so high, a number of localised campaigns have been initiated through the Gippsland Primary Healthcare Network, working with the La Trobe Health Assembly and the Department of Health to try and just increase awareness and to get men to think about ways in which that they can stop smoking. So lots of local campaigns. This particular campaign was called Pitch to Quit, and it was a competition. So it was a competition aimed at finding a local who would create an ad campaign that was generalised to the Latrobe area. And the picture that you can see there was actually the ad that was produced. So, and you can see it's targeting young men who are smokers, and it was filmed in a number of locations, a number of towns in the Latrobe area, so that locals could actually identify with this person and identify how they're going about quitting, but also to be able to see themselves in the picture. So to see themselves locally in the picture, because they're local identifiable locations as well. So it was interesting, as part of this body of work, we did a large community survey in this region, and there was a number of males, much higher than females, that were smokers, in particular former smokers. And of that, 93% of males compared to 72% of females all went cold turkey. So for as much as all the initiatives that we have out there for smoking and the help and the support that we can provide for them, everything from the quit line to working with GPs to nicotine replacement therapy, all of those things from pharmacists, it was cold turkey that was the highest percent for that all former smokers in this survey said that that's how they quit smoking. So it wasn't a combination of all those things, which was an interesting result. The other thing though, the current smokers, so if I just go back, this is former smokers saying this is how we quit, but the current smokers were a slightly different picture. They were still very much, and you can see, very strongly geared to males' way of quitting is to go cold turkey, but there was a lot more of a bit more, we'll consider going to quit line and definitely look at nicotine replacement therapies. They were a little bit more inclined to sort of even consider those other types of quitting support networks. So the current smokers were still, you know, this is interesting data because quit line's very generic, and it's not localized to a particular area or a region. It was interesting, about 12 months ago, we did these enormous big forums of males and females in this local area, and a high percentage of the males in this region, and this is coming off the bat of bushfire season and high unemployment rates, had said that the one joy that they have in their life is to smoke. And don't take away the one thing that I can actually, that I am empowered to control in my life. So there was a lot of talk, especially in the GPHN, to how do we target people that have really very little control over the rest of their lives, and that smoking is the one thing that they see is something that is joyful rather than something that they actually want to quit. Interestingly, though, they all talked about that they know the risks. They know the health benefits of quitting. That wasn't the issue. It was around the socialisation of smoking, and it was around the lack of control that they have in other elements of their life that actually was some of the barriers to actually quitting smoking. So some of the comments coming out from the research we did was around, I only smoke occasionally, nothing at all in the last 3 months, but when I do choose to smoke, I will enjoy the Zen moment and have no intention of deleting this occasional pleasure from my life. So this quote really highlights that this feeling of men in this area around the joy of smoking, and that it's one of the only joys that they have. I've smoked since I was about 16. It cost a lot to smoke, and I know the health risks of smoking, but I need that release and haven't tried to quit. But of those that did sort of talk about wanting to quit and understanding those health benefits, they were all talking about just going cold turkey, just do it. So from this body of work, we were able to sort of target some of those health campaigns and initiatives around the thought processes of the men in this region. And so the Pitch to Quit campaign was really around that you need help to quit. You can't just do it by yourself. But in fact, it's more of takes a village to raise a child, and it takes a support network of people around you to help you to quit as well, so that you can get into that good space of feeling the benefits of not smoking. So the males were more motivated by cessation tools towards quit attempt, definitely around the rising cost of cigarettes and the desire to save money. They did recognise that they had some physical symptoms now that was impacting on their health, and that there was a desire to get fit, and that they had some willpower. So the ad campaign was targeting that message. So it's an interesting one. The Pitch to Quit campaign is running for an 8-week or a 2-month period. And we're very aware that, when you do local campaigns, the local campaigns are in combination of national campaigns as well. So there's a bit of clouding of the waters as is to knowing the true impact of what you're doing locally. But in fact, what we're discovering is that it's a collection of different initiatives that will make a difference in the space. So it's good to be able to go on the back of national campaigns for smoking or for bowel screening and other initiatives, and localise some of your initiatives as well. So it's a really multi-pronged approach to targeting different communities. So one of the other outcomes of the large community survey that we did was really having a look at some of the screening initiatives and whether or not men in particular are taking up the challenge. And the bowel screening was an interesting one. There's a number of different national campaigns and ads on TV about doing the bowel checks. We wanted to know whether or not it was being taken up and actually being done by residents here in Latrobe. And interestingly, despite 95% of the people who filled out the survey receiving the test kit, only 80% then went on to do it. So there's still a missing 15% of the population that are sort of still getting it, knowing that it's important to do, but not taking it up. Of those males, 87% were more likely to complete the test compared to females. So that's saying that the targeting of bowel cancer initiatives or ad campaigns towards the male populations is working. But it's hard to say whether or not, females are bombarded by multiple other screening campaigns that relate to them. So they've got not just one, but multiple screening ads coming at them. But it is good to see that those targeted campaigns to men are meaning that we're getting a much higher intake of men taking or doing or completing the test. Males aged 50 to 74, about 86% of them, did recall the National Bowel Campaign. So again, that's really good to hear that they're listening to those. And they were very much more aware of the risks of bowel cancer, aware of the benefits of being tested, and they were more aware of what's involved at getting tested as well. So there was a lot of benefits to those national campaigns. The message is getting through, which is nice. Interestingly, 53% of the males in this survey reported speaking to their GP about the test, which is great. It didn't influence their doing of the test, but it opened up health conversations with their GPs, which we were really pleased with that result. It's great to see that that it's, even if it's sparking them initiating a conversation with a health professional, and that's a really good result. Another one of the initiatives, and again, multi-pronged approach to kind of getting and highlighting the need for screening for cancer, was a campaign called Screen for Me. And Screen for Me, and you can see on the left there that card. So it was a simple technique and a simple idea to have a card that basically said, if you're not going to screen for you, will you screen for me? And it was using an emotional trigger to get a loved one or a family member to go and have the screening. So there were a number of kits that went out, and the Primary Healthcare Network actually set up in cafes and on the street to actually set up with little Polaroid cameras to take photographs of people to then put into the cards for them to give to a loved one or a family member. Now, this initiative started in 2019 and had an enormous impact in the Latrobe area. However, with 2020, a lot of this initiative actually stopped. And however, tomorrow we've got a relaunch of this campaign. So knowing how successful it was in the region, we're not putting it to rest. We're going back out there to reinvigorate a community that has been in lockdown so that they can come back to coming and putting screening back in the front of their minds. So with this one though, it seemed to really, it really targeted, it was targeted at both genders, but the females were the ones that really took up this mantle. And so we're looking at really targeting men in the next version of this. It seemed to change female attitudes towards screening, but it didn't really affect the males. The females, 44% were more likely than males, 12% to get screened. What's missing in the evaluation, this element, is that we don't know what happened to the screen cards. So the next step would be to know, to actually talk to the people that the card was given to. So all we saw was the people who took the card, but not who they gave it to and whether or not it made a difference. Now, on the Facebook site, though, we were hearing stories. And so, you know, if we managed to capture just one or two different individuals, and because of the early screening, they actually picked up on cancers, that they were the success stories that we wanted to hear. But more work is being done in this area, but it's just one of the initiatives I wanted to highlight today. One of the other large body of work that is happening right across the Gippsland region is around suicide prevention. And, you know, if we pick up on the 2016 to 25 suicide prevention framework has 5 key objectives, and one of which a new commitment to test and evaluate new trial initiatives and share data with local communities. And that particular key objective has been picked up by a number of the large organisations, health organisations in the region, right from South Gippsland Shire Council, who have a large suicide prevention campaign and initiatives, a range of initiatives happening over in that region, and to Latrobe Regional Hospital Mental Health Services that covers right across from East Gippsland all the way through to Latrobe and into West Gippsland. One of the initiatives has been to try and test the zero suicide prevention strategy, which looks at suicide prevention pathways with health professionals who are doing mental health checks. What the aim here is to actually look at consistency of the way we're doing it, the quality assessment, formulation of safety planning, and education of mental health practitioners, which is the important part of this. This was a large body of work done in partnership with Latrobe Regional Hospital's mental health team. And one of the elements was to actually do a chart audit of all of their notes working with the zero suicide approach. What we found was that there were male clients were our highest percentage. There were 52%, 52% of the patients or clients were male, and the mean age was 40. We extracted data from January 19 through to June 2020 and looking at how those assessments were done. 61% of referrals came in from acute community intervention services. Emergency department is still the primary point of referral, 55% of cases. 53% of the cases were admitted, which is a high percentage of admissions, and 25% were crisis assessments. So there's a number of bodies of work that need to occur with the high numbers of males that are still at risk of suicide in this region. What we discovered, and it's interesting that in fact 25% of the cases had no formal diagnosis, so they were either new diagnosis or had not been in the health system previously, which is a high percentage. And this may be the first point of call that we're actually having contact with these particular clients. Of the ones we looked at, depression and schizophrenia are still the highest diagnosis. And in the suicide drivers, again, 51% had no specified suicide drivers. So there was no indication in there around what the triggers were for their suicide attempts. But the next one down, 24%, the biggest trigger found in the audit from mental health services was around family, friendship stresses, including relationship breakdowns. So, you know, these are the kind of the bodies of work that really inform other initiatives that happen in this region. So some important work. So the Zero Suicide Prevention Program is shown to provide a structured and effective framework for assessing and managing suicide risk in the community. Now, this is the interesting one. Even though it was trialled, the zero suicide approach was trialled in East Gippsland, so right up the other end of the state, 154 clients identified that they required assessment. Of the 154, only 97 clients were assessed. So that means 57 people who were at risk were not assessed. So people are still slipping through the system. So Zero Suicide is one initiative to try and capture people slipping through the system. It's not, it's being rolled out. The training continues and more work needs to happen in this space so that we have a much lower number of people slipping through the system that were identified as needing assessment and not being assessed. So this is a quote, what the other body of work as part of the, we did the chart audit, but we also interviewed mental health practitioners and in particular up in the East Gippsland region. And at the time of the interviews, they were coming out of the recovery phase of the East Gippsland bushfires. And there was a lot of work being done and a lot of identification of high risk to suicide post at that particular region, at that particular period of time and the disaster. So one of the comments from the practitioners was, it's never one driver. You can have somebody that's teetering on the brink and then you'll have something like this disaster happen. Quite often people deal with that disaster because they can't think about the other stuff. But it's after a while when you find out that they've lost everything that they've ever had, that's enough to push them over the edge. So the mental health team right across that region are very, very aware that it's been one thing on top of another, on top of another thing that so it's not just one trigger, it's multiple triggers. So setting up initiatives and supports in that region is really important. One of the other really important elements, and something that came out from interviewing these practitioners, is because of the location, and they're geographically challenged, and this is the problem with, you know, regional, rural and remote areas in Victoria in particular, is when they actually decide that this person needs an intervention, are they sending them all the way to acute mental health services for their benefit so that they know that they've done their job, or for the client's benefit? So often keeping them in community and community-based and keeping them with their support networks and within their community is a much better option than going to acute services. But again, this is one of the issues of very remote areas, is that the backup and the extra support and resources needs to be invested in this region to support the clinicians that work in this region so that they can support these people at risk and men at risk. So a part of that initiative, though, and it was really important, was that the clinicians felt that, I guess, having the confidence as to when someone needs admission as opposed to when somebody doesn't and can contain the community, asking the questions, engaged in the risk. So they found that they gathered confidence in their assessment. I want to jump down a couple of generations now to some work being done in Latrobe around Latrobe street games. And this is to engage with young men and teenagers and young adolescents. This is a really important work, and it's been going now for a number of years, 3 years. It was fully operational in 2019. It went virtual in 2020, and it's back face-to-face in 2021. And of this, we're finding that 89% of participants are feeling healthier, they're getting engaged. But I want to highlight the quote down the bottom. And it's around really having opportunities for young people to see good role modelling, to be active and physically active, but to have a conduit to actually have good conversations, but also to have another career option that they might consider, and especially around sport and rec. So definitely wanting to stay in school simply because of having a passion around scooting. So street games really is designed to provide different opportunities, not just the traditional sports. So it's not your football and your netball and basketball sort of or soccer area. Yes, that's incorporated, but it's not traditional club sports. It's getting out on the street and playing short versions of this. So for example, getting to the skate parks and those areas where young men are congregating, and being positive role models in those areas. making a huge difference, especially in small rural and regional towns where they're going out to the towns, and it's an entire community coming around the street games activity for the young people to actually become active. And in particular, especially when it comes to, this is a photograph of some young people that are part of a school system called Flexible Learning Option, where young people that have been traumatised or have learning barriers go. And the skate sessions that were put in because of street games actually created teachable moments for the staff, for students, and opportunities to have meaningful conversations, in particular with vulnerable young men. So a really important program. And just quickly around some other initiatives around pit stops. Pit stops are really great ideas to get and actually take health checks out to men and where men congregate. Pit stop was something that came about and has been going for a decade out at, say, Lardner Field Days and East Gippsland Field Days. And out at our power stations as well. So getting to where men congregate. And the idea was pit stop is around cars, identifying and making terminology that men understand. So if you're going to have your hearing checked, you need a pressure, hearing checked, you'll need the sound system. You know, if you need around drug and alcohol and mental health, you need to have your shock absorbers checked. So it's using terminology that they actually understand and pictures around how they understand. What we were finding in particular, say as an example, is pit stop out at Lardner Park, which is 4 days of farm world. Over 200 men were being seen during this particular time. They were coming back. Those farmers, that was their yearly physical checkup. Now, it was a really comprehensive program, and pit stop had everything from hearing, sight, blood pressure, and the blood pressure was and conversations were being had by second-year nursing students, as well as having GP and mental health counsellors there as well. So really comprehensive. They went to men's sheds. So it's going all out and taking it to the places. So it was really encouraging also men to go follow up on those. So you had your health check, you found something, and now you take it to your GP so you can follow up on that. So my two, learnings from, looking at all the different initiatives happening across in the men's space, and that's not even including the work out at South Gippsland around the initiatives out there, taking it to sporting clubs and having conversations, and definitely the work in the health assembly here, which is looking at creating a social prescribing worker and also a connector between men's sheds, is we need targeted campaigns that are age and gender specific, and we need to go where men are. My two sort of last comments when it comes to men's health. So thank you very much.
Great. Thanks, Jo. Coming in right on time. Is there any quick questions that anybody wants to ask Jo? Throw it open for a minute. No. Okay. Look, what I'm going to do is move on, and that gives us still some time at the end for some questions as well. Our last speaker is Dr. Neha Swami, who's a senior research officer in the Longitudinal and Life Course Studies team at the Australian Institute of Family Studies. She's the co-author of the report Findings from 10 to Men, the Australian Longitudinal Study on Male Health, which included research on overweight and obesity, mental health, alcohol use, and a chapter on health literacy and health service use among Australian men. Thank you. There you go.
Thanks, Greg. Thanks for the introduction. So I'll just share my screen for the presentation. Can everyone see the presentation?
Yep, we can see it.
So what I'll be presenting today, the topic that I'll be presenting today is men's health literacy and interaction with the healthcare system, findings from the 10 to Men study. I'm one of the key researchers on the research team that's responsible for analyzing this longitudinal data. Well, the findings that I'm presenting today, like Greg said, are part of the insights report that me and my team released last year. So if you are interested in more detailed findings, please go and have a look at the report. Sorry. This is the outline of my presentation. First, I'll go through the aims, then methods. Then we'll talk about healthcare beliefs and health literacy among Australian males. Then we'll look at healthcare engagement among Australian males. And finally, I'll end up with some key messages. So the aim of this presentation is to examine healthcare beliefs and health literacy among Australian males. Then we look at some factors that are associated with lower engagement and feeling less supported by the healthcare system. We'll also investigate the patterns for healthcare use among Australian men. And finally, we'll look at some factors associated with health service use among Australian males. So the data that I've used for the findings that I'll be discussing today comes from the 10 to Men, the Australian longitudinal study on male health. It's the first large-scale, nationally representative longitudinal study on men's health. It's funded by Department of Health. At recruitment, it recruited around 16,000 males aged between 10 to 55, which will be followed over time. So wave 1 was collected in 2013-14, wave 2 was collected in 2015-16, and wave 3 was collected last year from July to December. I won't be discussing any findings from wave 3. So basically, I'll be covering the findings that from wave 1 and wave 2 in this presentation. So the analysis sample for the findings that I'll present today comes from waves 1 and 2 on adult Australian men aged 18 to 57. At wave 1, we had around 13,000 Australian men aged 15 to 7. And of those, 10,500 also responded in wave 2. It's important to note that all the analysis that I will be presenting today is weighted. So the estimates are for the whole population. So let's first look at healthcare beliefs and health literacy among Australian males. So what this figure shows is healthcare beliefs among Australian men aged 18 to 57 years. What we find that while most Australian men, around 95% of them, considered health to be important, not all were taking steps to optimize their health outcomes. 2/3 of Australian males said that they actively look after their health. However, more than 3 said that they only visited doctor when they were pushed or forced to do so. Similarly, 4 in 10 men said that they completely avoided talking about their health, which is concerning because we know how important prevention and preventive behavior is for early detection of diseases and healthy aging, like Dr. Rebecca also mentioned. Then we also looked at health literacy among Australian males based on the health literacy questionnaire, and we looked at 3 main domains, which is men's ability to find good health information, their ability to actively engage with healthcare providers, and also the ability to feel understood and supported by healthcare providers. So let's move on to the first one in terms of the ability to access health information. So what we find that majority of Australian men, around 8 in 10, said that it was quite or very easy for them to find information about health problems, find information from several different places, get information about health so that they're up to date with the best information, get it in a language that they understand, and also get it by themselves and without taking help of others. Then in terms of ability to engage with healthcare providers, again, we find that majority of Australian men, around 8 in 10, reported good abilities to engage with the healthcare providers. That is, around 8 in 10 said that it was quite or very easy for them to make sure that healthcare providers understand their problems properly. They were able to discuss their health concerns with them, have good discussion with their doctors, and discuss things till they understand what they need to do and get information about what they provide questions or get health information that they needed to move forward with their health problem. The third domain is the ability to get support from healthcare providers. Here we find that proportions are slightly lower. So only around 50% of men said they at least have one healthcare provider who knows them well. Around 7 in 10 men said they at least have one healthcare provider that they can discuss their health problems with. They at least have one healthcare providers who will help them to work out what they need to do. And similarly, around 7 in 10 men said that they at least have one healthcare providers that they can rely on. So what the past 3 slides show that although majority of Australian men have good health literacy, there are few men, around 20% of Australian men who don't have the ability to actively engage with the healthcare system and not feel supported and understood by it. So we did a multivariate regression analysis to understand the factors associated with low health literacy in terms of ability to engage with the healthcare system and feeling supported and understood by it. And what we find that younger men, men in regional areas, men who have lower education, men who are experiencing higher financial stress, non-heterosexual men, and men who had higher conformity to traditional masculine norms were more likely to say that they are not able to actively engage with the healthcare system and feel supported by the healthcare provider. Then let's look at healthcare engagement among Australian males. So this graph shows the type of health services accessed in past year by Australian men aged 18 to 60 years in year 2015-16. And as we can see, the GP was the most commonly accessed service by Australian men in the past 12 months. More than 7 in 10 men in any age group went to a GP in past 12 months. It was followed by a visit to dentist. Although annual checkups with dentist are recommended, we see that only about 1/3 of men were visiting dentist in the past 12 months. The use of other services like chiropractor, psychologist, and nurse were even less common. Then in the data, we also asked men directly about their preventive behavior. That is how often they go to a GP for preventive reasons and not because they were sick. And what we find that only around 4 in 10 men overall said that they went to a GP for preventive reasons once a year or more. Obviously, the percentage increased with age. So among men aged 45 to 60 years, around 57% of men went to a GP once a year or more for preventive health checkups. But I feel it's still low, given that we have discussed the importance of preventive health screening and checkup for healthy aging, and even early detection of issues that we can prevent from happening later on in life. Then we also did a multivariate regression analysis to understand what are the factors that are associated with not using health services. And we used GP as a proxy for health services because GPs are usually the first point of contact with the healthcare system. And we find that, again, younger men in regional areas, single men compared to married men from culturally and linguistically diverse backgrounds, men who are employed, men who didn't have private health insurance, again, those with higher conformity to traditional masculine norms, and men who reported lower ability to engage with the healthcare system were less likely to visit a GP in past 12 months. So I'll go through some of the key messages. So what we find from the first 2 waves of 10 to Men study is that many men view seeking healthcare only a response to being unwell, although 2/3 of them said that they actively looked after their health. While GP was the most commonly accessed health service among men, around 1/3, that's around 3 in 10 men, did not see a GP in past 12 months. We also find that only around 4 in 10 men went to their GP for preventive annual checkups, which is quite low. And we would like the numbers to increase when we follow them over the years. And finally, although majority of Australian men reported good health literacy in terms of the ability to engage with the healthcare system, get health information, there were around 1/5 of Australian men who said that they do not have good ability to get health information that's up to date or to actively engage with the healthcare providers. An even higher proportion of men said that they feel less supported and less understood by the healthcare system. I think this is where the gap is when we looked at 3 health literacy domain the numbers of good health literacy for men were quite higher for accessing information or engagement with the healthcare system. But when we asked them their ability to feel supported and engage with the healthcare system, the proportions were declined quite significantly. So this is where I think the healthcare system is lacking, is men are not feeling supported or understood by the healthcare providers. We also find some clear gaps in the service use for certain populations. Like I said, previously mentioned, that younger men, those living in regional areas, those from culturally and linguistically diverse backgrounds, and the men who are socioeconomically or financially disadvantaged in terms of experiencing more financial stress, those who don't have private health insurance were less likely to see GP in past 12 months. So what this shows that there are clearly a group of men that are not engaging enough with the healthcare system and that need professional support. And we need to do more to help these men to engage better and more frequently with the healthcare system. It could be through educating them, but also addressing other barriers that they might face. That's it. Thank you.
Well, thank you very much. There's some really interesting figures in there. I'm just going to open it up now for questions to our last speaker or any of our speakers in this session. Has anyone got a question?
I have a question at Spot. I was typing something out, but I'm a bit slow. With all the data collected to date, what has been implemented based on the data collected to improve the men's health?
Do you mean, is that to our last speaker, Spot?
Yes.
Yep. Okay. Yep.
Thank you for your question. I think the data we directly report to the Department of Health, who is interested in knowing the barrier, was interested in knowing the issues that's impacting men's health and which group of men are most at risk. And we also looked at some of the barriers that men face and accessing healthcare, which the two most common barriers were cost and waiting time. So when we speak to Department of Health or other stakeholders, they find it really informative to understand and have this evidence on hand when they're implementing policies in the future. It's quite a new study. I mean, we've just started in 2013-14, and we'll start following men over the years. Hopefully, we'll have more evidence to convince policymakers about certain groups of men who are not engaging with the healthcare system and have more research and evidence on how outcomes can be improved for these men.
Yeah, because I get very concerned with the amount of surveys and data collected that is not getting out into the actual thing to help the men's situation out there. And, you know, as an advocate in wellbeing, I'm stumped, what improvements have there been to assist us, to assist our clients?
I mean,
that's what I'm concerned about.
Yeah, I think you can always use the evidence. I mean, if you look at the report, you can always use the evidence to make a case. I mean, if the policy action is ultimately in the hands of the government, but it allows us to make a case for policy change and interventions and where they can be targeted to which groups.
I'm a skeptic. I'd like to see a lot of that money given to me so that I can improve the housing and the quality of life of some of my veterans and stuff like that are suffering out here. And I don't see it. That's what I'm looking at. I don't have blinkers on. I'm quite open-minded, but I do see, if you look at Coffs Harbour, we're suffering from chronic housing that I could put in a veteran that's suffering, say got an AVO out on him from his suffering. I can't get him into accommodation. Things like this. This is what I'd like to see in some of these surveys come up and use both sides of the game. you know, and I'm not seeing it. Anyway, that's my thoughts.
Yep. Thank you, Spot. There's a few things in that. I think 10 to men only goes up to 60. Is that right?
It started with the cohort of 10 to 55, but as we follow them,
you're into 60 now. Yeah,
with females.
Yeah, I mean, and for me in those figures there, because of that age group, even when you showed figures about who do people go to see, that age group sort of doesn't go to see a lot of specialists. If you looked at people from 60 to 80, you know, I have 5 specialists who I see at the moment. I won't go into why that is. But yeah, if we looked at an older age group, and just a quick one, you said that 2 of the major things for you about why men are maybe not taking up services was cost and waiting time.
Yes.
Right. To me, when I hear that, that's a structural problem in our health system. That's not a problem about men.
Yeah.
At all. You know, we need to make services free and available to men. If we did those things, we'd have a better uptake. So yeah, it's just a point as we're going along.
That men in regional and remote communities are not engaging. It could be because of barriers. So I think very good point.
Yeah, that's right. I'm just having a look at the chat box now. And any idea about the number of young people who were part of the study and how many were from culturally and linguistically different backgrounds?
So in terms of younger men, so we from age 10 to 17, we had about 2,000 younger men in the first wave. Obviously, as they will age, the cohort will age. But to begin with, we had around 2,000 of men aged 10 to 17. And in terms of culturally and linguistically diverse, around 6% of the entire, 6 to 7% of the entire initial sample was from the non-English speaking background.
Oh, okay. So 6%. Okay.
Yeah.
Right. Okay. Are there any more questions?
Greg, Brad had a question for Joe Porter.
Yep.
Hi, Joe. I'll just expand. I left a bunch of typos on the question, so I'll just expand it a little bit more. Just recently, we had a Lord Mayor's Roundtable here in Orange, New South Wales, where the Minister for Mental Health here, Bronwyn Taylor, was involved, and there was about 60 odd people attending from Public Health Network, local LHDs, local community providers, some community members, etc. And one of the big consensuses that came out was that there are a lot of community-based services out there, like the ones that you talked about, but no one knows about them. And so she's actually committed, or they're funding a role to help sort of try and coordinate that information and pull it together. And I just thought the research that you did, and I did come at the tail end of it, apologies for that, was great, and a great way of being able to aggregate that information and then disseminate it out to the community and community providers and various other people that have a vested interest into that, including EAPs, major employers, because the thing that has come out in spades in the last 2 years since I've got actively involved in Orange here is that people just don't know what's available. And so when the clinical services are overrun and the queue times for a psychiatrist here in Orange is something like 18 months, where else can they go and what other services can they provide? That seems to be the big challenge.
Brad, I feel your pain. And it's interesting working in this space, and in particular in Latrobe. One of the initiatives that came out of the mine fire, there was an awful lot of money that was invested into Latrobe. And one of the recommendations was to actually create the Latrobe Health Assembly. And the Latrobe Health Assembly has over 42 and growing organisations and agencies that are connected to the Assembly to be able to share learnings. And that's made a difference in Latrobe, but it's still only in the infancy. It's still only a few years in, and whether or not that's making a difference. The problem is that we don't often get all the players, all the right people sitting at the table to be able to move forward. And the biggest barrier that I'm seeing with any one of these initiatives, because these initiatives are great, but they are short-lived. And with federal funding, for example, there was an amazing campaign called the Hello campaign, which was getting out into community. It came out of Lifeline, our local Lifeline. But its funding ran out, and so did the project. And people, I think the other thing about residents are getting, you know, they want to try and test things. They want to see us doing stuff, but they also, when something works, we need to be able to find a way to sustain it. And the only way that I can see some projects being sustained is where we've got members of the department and federal government being informed right from project initiation, so that they can take ownership of it and get sustainable funding moving forward. Because a lot of it, for example, Street Games has been going 3 years, it's making a significant difference, and it's struggling to actually sustain its funding going forward. Yep.
Well, they have the same thing here with the RAMPS program, Rural Advisory Mental Health Program, I think it is. They have their annual funding, or every 3-year funding, and they're not sure right up until nearly the renewal time that it's going to go ahead again. There's a lot of community programs that aren't reliant on it. We saw a few yesterday as well that aren't reliant on federal or government funding, that have been going for a while. I'm involved with one called the Banksia Project, and they've been around for about 5 years, and they have some government funding, but the majority of private funding, and they pick and stick in the local community. And but getting that information out and consolidating those services, I think, you know, it seems to be a common thread along a number of forums.
Sorry, we've actually come to the end of this session. I'd just like to thank all our 3 speakers for their time and for their input today. I think there's a whole lot of information in there that we can use.